So it prevents the side effects such as nausea and stomach irritation. Hence the name Sinemet. So the brand name for carbidopa levodopa, if you will, is Sinemet. Sin is without, and emet is emesis. So it's without nausea. So that's what it means, and that's where the name comes from. And the next important thing to talk about is when to start this medication. And number 2 question is, if I start early, am I going to get dyskinesia? There's a lot of fear about dyskinesia as well. So I wanted to kind of answer that question too. And number 3 is, does it slow down the disease? And I will answer that question as well. The busy slide here, to answer the first question, when to start the carbidopa levodopa. The short answer to that is, you start the carbidopa levodopa when the symptoms are bothering you. And let me just highlight the most important part here. The most important part in this slide is highlighted in yellow circle here. So let me see if I can get a pointer here. So as you can see, the top part is the early levodopa strategy, and then the bottom one is a levodopa sparing strategy. To give you a little bit of a background history is that the bottom strategy, levodopa sparing strategy, came about after maybe 3-4 years of starting when the levodopa came out, because doctors noticed that people who are on carbidopa levodopa start to get dyskinesia after 3-4 years. So everyone got scared and it was like, oh no, we don't want this, we don't want this. Let's let's have patient not take this carbidopa levodopa because it's gonna lead to dyskinesia, and let's hold off, let's use something else. And people have been using dopamine agonists such as ropinirole, pramipexole, or MAO-B inhibitor, which I'll get into later, like such as selegiline and razazoline. So initially, when the first levodopa, when levodopa came out first time, it was like, oh, great drug, miracle drug, let's put everybody on it. And then 3-4 years later, dyskinesia came about, and then everyone's like, oh, let's stop doing levodopa, carbidopa. But later, we found out that if we do this levodopa sparing strategy, it will cause early high disability. So all the time that you're not on carbidopa levodopa, you're kind of suffering. Because it's not treating all the way. It's not hitting the spot all the way. Although because it's not hitting the spot all the way, it's not causing dyskinesia, but at the same time, your symptoms are not really under control. So nowadays, we've been
Hey, Dr. Kim, can I stop you just a second? Can you explain really briefly what dyskinesia is for those who may not be familiar with that term?
Yes. So dyskinesia is probably more familiar if you've seen Michael J. Fox on TV. So it would be more of like kind of shoulder movement, arm movement, kind of like described more as a dancing-like movement. It can be also kind of tonic, kind of spasm, like foot turning in, and so on and so forth. So those are some of the dyskinesia you can get later in the disease. And I'll talk more about on the next slide, if I can go to the next slide. So the next slide talks about more about the dyskinesia. If I start carbidopa levodopa early, am I going to get this dyskinesia, which happens more so when the carbidopa levodopa is working at its full efficacy later in the disease. So it's not just about medication causing it, but it's a combination of medication and progression of disease. So your receptors, dopamine receptor in the brain changes over time, and that's the time when you get the carbidopa levodopa induced dyskinesia. You don't get it all the time. So if you start right away, let's say, oh, you just got diagnosed a couple of weeks ago or 2 months ago, and you're on carbidopa levodopa, oh, am I going to get dyskinesia now? No, you're not going to get dyskinesia unless you've been having Parkinson for 10, 20 years or 5-6 years. You're really not facing this. And oftentimes, patients who get this dyskinesia, they rather prefer to be in dyskinetic mode as opposed to off frozen mode. The frozen meaning you cannot move, it's just, cannot get out, your movement is very restricted. And so most patients prefer to be in dyskinetic, like kind of moving around, dancing around, as opposed to frozen mode. So it speaks to the idea again, if you're not on carbidopa, levodopa, you're really undertreated. So to summarize and answer the question number 2 is that, is it going to happen earlier? Sure, it can, but at the same time, we prefer patients to be on levodopa because it's going to lower the disability in an earlier stage. You're preventing that missing out period by not being on the medication. So that's number 2. Number 3 question is, does it slow down the disease? There was a recent study in 2019 looking at this. There was people who were in a delayed start group of the carbidopa levodopa as opposed to early start group. As you can see, since they're all already on the medication, the disease scale goes down and then it stays down, and there's some progression over time because over time it progresses. And the delayed group gets converted into the regular group, and then there's no difference. So there's no difference between people who start early versus late. So if there's a protective effect, you will see this line lower than the delay start group, but we did not see that. So to answer this question, does carbidopa levodopa slow down the disease? It does not. And conversely, does it make it go faster? No, it does not. It doesn't affect the disease as far as we know so far. Moving on to different medication, dopamine agonists. And I know some of the patients who've been diagnosed long ago probably has been on this medication. It's pretty effective medication initially, and it's a good medication, and it treats restless syndrome pretty well as well. And these are the type of medication: ropinirole, pramipexole, rotigotine patch, Apican injectables. Kimobi is also available nowadays. The main problem with this medication, more so in the later in the disease, is that, or any time actually while on the medication, is impulse control disorder. So I have this lottery ticket showing up on my slide. What can happen with this medication is that you get impulsive with your action. It can get rather problematic, such as buying lottery tickets over and over again, and to the point that we had a patient where they were spending thousands of dollars per month just on the lottery ticket. So that kind of thing can happen, and it can be other simpler thing. They'll just buy cans of soda over and over again, and it just gets stacked up in the garage, and it's just becoming bad over time and whatnot. So that can be a problem with the dopamine agonist. The top picture here is showing sudden sleepiness with the dopamine agonist it can cause. So when it first got reported, people were getting motor vehicle accident because it was leading to sudden sleep attack, and people were getting that. So that is something that you should look out for. Moving on to adjunctive medications. So MAO-B inhibitors, COMT inhibitors, those are the ones that are designed to make carbidopa, levodopa last longer. It can be a lot of MAO-B inhibitors can be used as a single agent as well in the initial stage of the disease as well. So you might have been started on razazoline initially, maybe a few years ago, because there was a lot of interest about razazoline before, because they thought that it might slow down the disease, but it turns out it didn't. The main problem, so as the disease progressed, this is the graph of your on state and off state, if you will. So you take your carbidopa, levodopa, let's say at 7 a.m., and it goes up in the bloodstream, and then you're on the good time, on time, you can move better, your tremor is better, and then it goes down and you take it again, and so on and so forth. So it's perfect during the first a few years of the disease course and you don't have any problem. And then we move on to the problem. You get motor fluctuation, you get dyskinesia as the disease progresses. So what happens if you take the medication, it takes some time to get on. And then when it peaks, you start to get that dyskinesia, like dancing-like movement, and then it goes down. And then it wears off before 12 p.m. So it wears off maybe 3-hour point and you're off and frozen and so on and so forth. And it becomes a problem. And there's many ways to go about fixing this. And you can increase the dosage, you can increase the frequency of the carbidopa, levodopa. And sometimes you can use these medication, MAO-B inhibitors or COMT inhibitors, to kind of make it like this. So what it does is it makes it last, it will peak more and last longer so that you have a less of off time. However, as you can see, since it peaks more, what happens is that you can get more dyskinesia, and sometimes you might have to adjust the carbidopa, levodopa lower so that you're not getting that dyskinesia. One may argue that then why not just make, have patient take just more frequently instead of adding this medication, and that's perfectly valid option as well. There are other medication, adenosine receptor antagonists. There was a interest where they found that caffeine was felt to be helping the Parkinson's patient with their symptom, and they looked into it and realized that it was binding to adenosine receptor and helping with the dopamine pathway. So they came out with this new medication, which is expensive. My argument to this is that why not just take caffeine if we're thinking to do this, instead of paying pharmacy a lot of money to pay for this new medication. Side effect, obviously, because it binds to this receptor, is similar to caffeine. You can get insomnia and so on and so forth. And efficacy, I will say that it's probably not as strong as carbidopa, levodopa. Really, carbidopa, levodopa is kind of the mainstream, is the most powerful medication that's available. All these other medication that I'm going through is really to help out with the carbidopa, levodopa, and less effective. Other medication includes amantadine and clozapine. Amantadine can be also used initially to treat tremor. To give you a little bit more information about tremor in Parkinson's patients, is that about 20 to 30 or 20 to 40% of Parkinson's patients who are tremor dominant. So instead of having a lot of stiffness and slowness, they have more of a resting tremor. And it's those patients, about 20 to 40% of those patients can be refractory to carbidopa, levodopa for their tremor symptoms. It still works for their slowness and stiffness, but it can be refractory. And sometimes doctors can use amantadine or other medication that works on the muscle receptors than anything else. Amantadine also has the dopamine effect too, and also other glutamate effect and other receptors it binds to. And that's how it actually helps with the dyskinesia, but it can be used for tremor too. A main side effect of amantadine is insomnia. So make sure that you're not taking this too late in the afternoon. Clozapine is another medication. It's actually antipsychotic medication. It's underused, I want to say, mainly because you need to have blood drawn every week for first 6 months. So nobody wants to have that, and no doctor wants to have patient go through that kind of nuisance. So that's probably reason why people are not using it, but it can be effective treating all these three symptoms: dyskinesia, tremor, as well as hallucination. So that is something to consider. Moving on to, how are we doing with time? Okay, we're doing okay, I guess. So moving on to procedure for motor symptoms. The first one that I talk about is Botox. With the Parkinson patient, and I'm sure Dr. Lin, was it? Talked about this during the talk probably yesterday. So Parkinson patient can get cervical dystonia. They have neck stiffness. They cannot move their neck very well. They get neck pain, and you can get Botox injection for this. And it can be quite effective in treating those. One caveat to that is that if you're having a lot of neck drop, that Botox cannot really treat that neck drop too much. So just keep that in mind. You can also get foot dystonia, so your foot may go, turning inward as opposed to outward, and it can be seen as kind of wearing off effect or on dystonia type of effect, and that can be treated with Botox as well. And some people might get toe curling, and that can be also treated with Botox if it's bothersome. If a patient has a lot of jaw tremor, and that can be treated with Botox as well. And Botox works by kind of relaxing the muscle, and so you have less of that muscle activity. Moving on to even more invasive procedure, deep brain stimulation. This is a brain surgery. It treats shaking, slowness, and stiffness. So those are the three main symptoms. I have to kind of clarify that. It doesn't treat sleep. It doesn't treat walking. It doesn't, make your anxiety better. It doesn't do that. It just treats these three symptoms. So just keep that in mind if you're thinking about this. It can make some symptoms to get worse. So you have to also get a good evaluation of these three domains. Physical therapy to take a look at your walking and making sure you're a good candidate in that sense. And going through the swallowing evaluation just to make sure that you're swallowing okay, and also neuropsychology testing to look at making sure that you're not developing dementia. Because let's say if you have a good reserve, a big reserve in those domains, and you have it goes down slightly with the deep brain stimulation, it's okay. However, if you have a very low reserve and you do the surgery and let's say you have some symptom and worsening of the symptom and you became demented because of it, then we did disservice. So it's very important to go through the candidacy evaluation. There are rare serious complications. It's rare, which about 3% chance of bleeding, which is very rare compared to other surgeries out there. But it is still real risk. If it happens to you, it's 100% instead of 3%. So it's something to think about and something to discuss with your neurosurgeon if you're expecting that. One thing to clarify again, expectation is about 60% symptom reduction. It can be higher than that, more for tremor, I want to say. But just on average, it reduces about 60%. It's a good option, especially if you're having off time, or if you're having more off time and having more dyskinesia when you're going up on the medication. So it can give you more, it will give less of off time and more on time without dyskinesia. There are newer treatment as well, focused ultrasound. It treats the same symptoms, but you can only get it on one side of the brain, so it only treats one side. So that's one thing to make sure you keep that in mind. It can worsen same kind of domains as DBS does, and evaluation is the same as DBS. The main pros of this procedure is that there's no risk of brain bleed. There's no risk of infection. However, the procedure itself is pretty much the same as burning a scar into your brain. So it's irreversible. If you get a side effect, you're stuck with it. You're gonna stuck with that side effect entire life. As opposed to DBS, you can turn it off. You can move the stimulation in different areas so that you get less of side effect. So usually movement disorders prefer DBS over focused ultrasound, but it is something that you can consider. DUOPA, which is intestinal gel delivery system of the carbidopa levodopa. As you can see here, as the disease progresses, you get dyskinesia when the medication is going up on the system, and then you go down. But you really want to be in that sweet spot, and you're seeing dyskinesia when it's too high, and when it's low, you're off time. It's just bad cycle overall. And if you're having that, and if you're not a good DBS candidate, then this is something to consider. What it does, you start in the morning, you get the infusion going, and you stay it pumps continuously so that you are in that sweet spot, if you will, throughout the day. It is invasive. You put the tube into the skin, into the stomach, and it goes all the way down to jejunum, where it gets where the carbidopa, levodopa gets absorbed the most, and it helps with the symptom. One requirement I want to say that you want to have a caretaker who can work with this machine. It's a pretty simple machine. You just put it on, you turn it on, and you click 2-3 buttons. That's about it. Big advantage is that you're okay to have dementia. You're okay to have swallowing difficulty. You are okay to have walking difficulty before getting this procedure, because basically you're just replacing the delivery method of the carbidopa levodopa. And these are the different styles that you can get. You can get it in belt, hip pack, vest, fitted vest, and chest pack, and all this kind of stuff. All right, moving on to management of non-motor symptoms. Number one is constipation. The first thing to do is, making sure you're walking around, you're exercising. You got to get that gut expanded, and so you're standing up, not sitting down, all cramped up. You want to be walking around so that you're, moving the bowel. You want to increase the fiber intake, increase the water intake. And if those doesn't work out, then you can try, the most benign thing to try is a Miralax, which is polyethylene glycol. And people, I think one of my patients asked me, is this the same as antifreeze? And it is not. It sounds similar. Antifreeze is ethylene glycol. Polyethylene glycol is completely different molecule. It has this number 3,350. It shows how long this part of the molecule is, and that goes into this N number. And it's a really long string of a molecule, and it doesn't get absorbed by the body. And what it does, it just puts water into the stool and makes it more soft, and then you have the movement. So think of it more like a sponge, if you will. So you take it, and then the sponge will put the water into the stool, and it comes out with the water, and the sponge will also come out as a stool. Senna and other laxatives are more activating to the muscle and maybe more harsh to the bowel, but it can be used. And because Parkinson patients have a difficulty with constipation, this is something that you can also use every day. And a whole list of other symptoms. I'm sure was it Dr. Lin or Dr. I forgot the name.
Yes, it was Dr. Lin. Yes.
Yes, Dr. Lin probably talked about all this. So you can get dementia. You can treat dementia with all the medication borrowed more from Alzheimer's disease kind of spectrum. But sometimes it's more effective when it comes to treating Parkinson's disease dementia as opposed to Alzheimer's dementia. So something to think about. Depression, you use other common antidepressants such as sertraline, venlafaxine, mirtazapine, trazodone. I tend to use mirtazapine and trazodone a lot because oftentimes Parkinson patients have that sleeping issues, and these medications help with those. Mirtazapine, interestingly, it can also treat the tremor sometimes. So that's another fact. Drooling. One thing I didn't include here, drooling, the first thing to try is actually chewing gum to make sure that you're swallowing your own saliva instead of Parkinson's disease kind of taking over and making you not swallow. And these medications, people shy away from because it can cause cognitive side effects. So it's not always a great thing to put patients on. You can try both botulinum toxin injection for salivary glands as well as parotid glands where it secretes the saliva. In my experience, it has been more like 50-50. So 50% of my patients will respond, 50% doesn't. As opposed to if I use botulinum toxin or Botox on other conditions like cervical dystonia, the neck or the foot, it works really good. But for drooling, for some reason, it just doesn't work that great. Daytime sleepiness, make sure you're sleeping at night, so treat insomnia. Exercise, usually it can be stamina issue during the day, so you're lying down, sitting down longer time, more likely that you're gonna sleep during that time. So you wanna get out there and exercise as much as possible. and then build that stamina. You can also think about using stimulants such as modafinil or Provizil that can be helpful. Insomnia, Parkinson's disease patient actually requires a lot of melatonin, and that can be helpful. So if you go over the counter, it will be like 5 milligrams, 6 milligrams, or even 3 milligrams. But for Parkinson's patient, you want to be using 15 or 20 milligram. And as I mentioned before, mirtazapine, trazodone, which is listed for the depression, can be used for insomnia, and it's pretty quite powerful. Sexual problem, people don't talk about it too much, but it's important. Parkinson's patient has erectile dysfunction. Parkinson's disease patient have a decreased libido. And these are some of the medication you can be on as long as the primary care doctor is okay with it, meaning you don't have any cardiovascular condition that prevents you from taking this. So this is important. So you just bring it out to your doctor if this is something that's happening. Urinary problems is more of an overactive bladder, so don't confuse it with prostate issue. If enlarged prostate will cause more of blockage than overactive bladder per se. There's a medication for it, but the main side effect is this. What do we see here? So we see confusion, cognitive problem. So these medications, just like other anti-drooling medication, can cause this confusional look, if you will, and hallucinations and whatnot, potentially. So it doesn't happen all the time, but it can definitely happen mechanistically speaking. So people shy away from these medications. There is a newer medication, Myrbetriq or mirabegron, which can be used, but because it's a newer medication, it tends to be expensive, but it doesn't have that confusion side effect. You can also use bladder and botulinum toxin for bladder. I hear usually that this is very painful. I'm not exactly sure how effective this is, but I want to say probably it's also another 50-50, just like drooling indication for Botox. Moving on to restless leg syndrome. Just keep in mind, restless leg syndrome is sensory phenomenon, meaning it's not like, oh yeah, my leg is moving. No, it's more like, oh, I feel this discomfort. I feel this pain in the legs. It's happening at night, and it's, you know, it's preventing me from going to sleep and so on and so forth. I have to move around to get better, and that's where the name is coming from. You have to move around, walk around to get better, and that's why it's called restless leg. Not because it's just moving out of nowhere, but because you have the symptom of this discomfort. And it can be improved by actually the carbidopa, levodopa. A lot of dopamine agonists can treat the symptom, and also gabapentin can treat the symptom as well. REM sleep behavior disorder, rapid eye movement is what it stands for. So basically what it means that you're in dreaming state, and during this state, you're supposed to have no muscle movement. Your brainstem is supposed to turn it off so that you only have eye movement while dreaming, but this get disinhibited. So it's supposed to be get inhibited, but that's get disinhibited. So it's, you get that movement. So at nighttime, you're just jumping around, moving around, you know, and you're falling out of bed, that kind of symptoms. First thing to do is actually you have to rule out sleep apnea, because sleep apnea can also cause movement at night when you're sleeping. You know, because you can imagine if you're not breathing at night and your body actually moves so that it can get to the position that they can breathe. So just have to make sure that you're not having sleep apnea, because the treatment is totally different. So because this medication, like such as clonazepam, which is a muscle relaxant, kind of worsen the sleep apnea. So you just make sure that it is not that. Obviously, you can use melatonin, which is more benign medication. Lightheadedness is rather common in Parkinson. It can be due to carbidopa, levodopa. Obviously, you want to be doing more conservative therapy, compression stocking, more water, more salt. And you can ask and look through the medication that lowers the blood pressure and ask primary care doctor, can we lower this or be off of this medication? Because oftentimes Parkinson patient, your blood pressure, the real blood pressure for you is probably more when you're standing. So as opposed to sitting down, if it's elevated, then try standing up and measuring it again, and you will notice that it will be in the normal range or lower range. If it becomes more of a problem, there's medication that we can try. The first one is a hormonal medication that makes water and salt to be retained in the body, and that's how it helps with the pressure. Midodrine squeeze down on the vessels, so that's how it works. Predostigmine, it kind of dilates different vessels so that it helps with the symptom as well. Droxidopa is primarily for Parkinson's disease related lightheadedness. What it does is it becomes norepinephrine, another medication that another molecule that Parkinson's patient kind of has low level of in their body, and it becomes that. And some people also use atomoxetine, which is kind of similar to droxidopa. It makes that molecule more available for the body. I think this might be the last non-motor symptom with the treatment. So hallucinations. So I have this rabbit running around. So what I usually tell my patients, if it's benign hallucination, let it be. If it's not bothering you, let it be. If it's just a rabbit running around, let that rabbit run around. Okay, you don't need to jump into try to get treatment, because oftentimes the treatment will make your Parkinson's symptom worse, because you might have to discontinue the dopamine agonist, may have to discontinue the amantadine, may have to decrease carbidopa, levodopa, and so on and so forth. So if it's just rabbit running around, let it be. There are other antipsychotic medication that can be helpful. So Seroquel is one of them, and clozapine, as I mentioned before. Pimavanserin is a newer medication, more antidepressive category. It takes a long time to kick in, 3 to 4 weeks to kick in. So if you're, experiencing paranoia, like, oh yeah, I'm actually not seeing the rabbit, I'm seeing a person who with a gun trying to, come into the house, and I'm locking my house away, I'm getting my gun ready and everything. So if that's happening, you want to be on Seroquel, because it works right away, as opposed to pimavanserin. Is you probably see it on commercial. Oh yeah, it's great for hallucination for Parkinson's, but it's like it takes forever, 3-4 weeks. We don't have time for that. Moving on to clinical trials, and I'll probably go quickly here, as I have been doing. So there are many clinical trial medication. One of them kind of is targeting, or a few of them targeting alpha-synuclein by antibody mechanism, vaccine mechanism, different mechanisms to attack the alpha-synuclein, which is the protein which is felt to be the culprit of causing cell degradation and dopamine factory to shut down. So this is the molecule they're looking after. Past few years, there has been an interest about GBA gene mutation, LRRK2 mutation, and Parkinson's disease, and they're developing gene-specific therapy. So there has been more push for testing Parkinson patient for genetic mutation. Keep in mind, most of the Parkinson patient doesn't have a gene mutation, but there has been more push for testing this. Old drug, new purpose. So there has been interest about exenatide under the name of neurology trial. It's a diabetes medication that can be used, and they're hoping that it might have neuroprotective effect. Same with this antioxidant blood pressure medication, as well as this leukemia drug, hoping to see some effect there. They're developing new medication for dyskinesia, because we really don't have much other than amantadine or clozapine. And there are many more. So it's not really showing up on the screen here, but can I click it? Just gonna get rid of my pointer. I click it. Does it show the internet? Jen, maybe?
It does not.
It does not. I have to change.
Yeah. I can show it after you're done, though, how people can find out about it. Oh,
now?
there it goes.
Yeah. Well, it's not APDA website. It's a Michael J. Fox website.
It's okay.
No pun intended. But so you can go on to Fox. I like this one because it asks you, oh, yeah, what kind of condition do you have? Oh, yeah, I have Parkinson's. So I click that. Go to next. And then, and then it asks you, you want me to just guide through, or do you want to just do it on your own? I recommend just guiding through, and you hit next. And what's clinical trial, and blah, blah, blah. And then it talks about that, which is very important. So read through them. And it talks about, oh, yeah, I want to be near my place. And I type in my clinic address, maybe. So I go, I'll probably go 50 and type in, I had symptoms for 3 years. Have you had deep brain? No, I don't have deep brain stimulation. And then, have you been diagnosed dementia? No, I don't have dementia. Or you might have dementia, and you put yes. And let's say, are you taking carbidopa, levodopa? Let's say no. So if you go to that, like get me to the nearest location, then it will kind of indicate, oh yeah, there's a place at Evergreen that you can be on that alpha-synuclein or SYN1 study. I think that's a biopsy study looking at skin. It's really, and there you can click the show next one. And then it says different studies and so on and so forth. I think Evergreen has the most clinical trials, I want to say, nearby where I am.
Correct.
And then if you go more towards Seattle, then University of Washington is the main one. So all these different studies that you can be involved in. So that's that. And let me just switch back to my slide. All right. So that's it. And I'll have some time for question and answer. People have been waiting for. Shout out and fire away with your question.
Great. How about you stop sharing your screen?
Got it.
Then feel free to either type your chat or question in the chat, or unmute yourself and ask your question, or wave your hand and I can call on you. Has a lot of information, a lot of different medications, a lot of things that can happen with Parkinson's.
Right.
I like to call Parkinson's your own couture disease. You have your own fashion of Parkinson's. Yes. So the things that Dr. Kim went over, are things that can happen with Parkinson's, but everybody's a little bit different. Exactly.
Yeah, I think Jen has a great point there. As I was giving the talk, I was a little bit worried too. Are they gonna be worried about all the symptoms that I'm talking about? And am I gonna have this? Am I gonna have that? No. The simple answer to that is no. You're gonna have different symptoms. You're gonna be different. Not everyone has these list of symptoms that you have. So don't worry about that. But if you do have those symptoms and you want to know more about it, you can ask those questions. But yeah, you're not gonna have all the symptoms that I listed, and everyone's different. So don't worry about it. If you have time to worry about it, I say exercise, because it can slow down the disease,
which we will talk about next week. Yeah, and one of the things that I think is important about bringing up the different things that can happen is, like, Dr. Kim mentioned hallucinations. For years, no one talked about it. And people were like, I think I'm going crazy, but I don't want to mention it to my doctor because I don't think it's part of Parkinson's. So if you bring awareness to it, then there's things that we can do about it versus just ignoring these symptoms. So it's not meant to be scary. It's meant to prepare just in case. So, yeah. So what kind of questions? Any questions? Yes, Debbie.
I just started, I was the one who was diagnosed on Tuesday, and I just started the Cinemet Wednesday morning, so I'm super light dose of half a tablet in the morning only. So my question is, there's a humongous amount of drugs out there for all the different various symptoms. I'm just on the Cinemet. So I guess my question pertains to that drug itself. Is there a list of contraindications for, for supplements or herbal products, things that you shouldn't be taking along with cinnamon? I think I'd asked yesterday the question about iron supplements as well. So just want to make sure I'm not taking something that's going to adversely interact with cinnamon.
Great question. Let me just make sure that I heard it correctly here. So you were worried or wondering about if there's any, restrictions or any things that you need to be doing to maximize this therapy and make sure that I'm not hindering the medication in any way. Is that correct?
Right, by taking something like iron along with the Cinemet, or magnesium or turmeric, or what should I take out of my supplement regimen that will—
Great question. So usually when you first start, a typical situation is that you're still early in the stage, and you don't notice much of an issue with the medication per se, not like medication not working properly and so on and so forth. So during first few years, usually you might not even notice much of a difference. Oh, you feel different, you feel better, but you might not feel much of a difference too. So, but to answer that question, yes, the main thing about carbidopa levodopa is to minimize protein intake together with the medication.
Okay.
Because carbidopa levodopa is amino acid medication. And if you take more protein, it competes with other amino acid in that protein and reduce the absorption. So it can decrease efficacy of it. It becomes more of a problem later in the disease when you're feeling more off time, when you're thinking that the medication is lasting 3 hours instead of 4. But during the first stage of the disease, it really isn't a big deal. If you drink some milk or eat some peanut butter with it, it's okay. The police won't catch you. So all in all, I think I want to say another comparison I want to make is I think it's not as harsh as some like thyroid medication where you really need to have empty stomach and whatnot. It's okay to enjoy your meal. It's okay to take it with food if needed. Some patients have stomach problem with it. So I tell the patient, take it with cracker, take it with some, I don't know, and stuff like that. If it's irritating your stomach, go ahead and eat it. If it's protein, so be it, eat it. It's fine. It's okay.
Okay.
But by all means, I think you're doing the right thing.
Okay. Thank you.
And kind of a related question, Deb, I'll get to you in a second. I'm going to take one from the chat. So the doctor prescribed 4 doses of carbidopa levodopa. Mom reduced it to 3 because of lightheadedness. Is there a typical consequence of reducing dosage? I know from talking to a lot of patients, they do mess with their dosage a little bit with the help of their doctor and sometimes without. So can you talk a little bit about that?
Yes, my thinking is that probably we increased the dosage because she's probably having more symptoms. So going up on the dosage will potentially treat the symptoms more, but it's hard to know whether it's 4 doses as in 4 tablets a day or 4 tablets per dose, or is it 4? But regardless, yes, if you increase the dose, it will treat the symptom more. If you reduce the dose, then you might have more symptoms. If you're going into lightheadedness, something to consider is that's still, I will say 4 tablets a day. I say probably then she's taking like every 4 hours or so. I'll say that's still in a low kind of amount. But however, if she's facing the lightheadedness, I will say talk to the doctor. There's a medication, as I mentioned before, lightheadedness. You can add those medication to help with that symptom so that you can take the medication. You can also think about taking extended release form of carbidopa levodopa and that may help with the lightheadedness as well. There's many strategies that you can go about doing, but you just have to let the doctor know, oh, this is happening. What can we do? Instead of you doing the changes, because you might not know what other options you have available.
Yeah, great. Deb, you want to ask your question? And then we'll go to the next one in the chat. Oh, you're still muted.
If you already are having the lightheadedness as part of your Parkinson's symptoms, like every morning, I usually have it. I've been having it for years, but nobody ever guessed it was Parkinson's. And then, you know, I start on the carbidopa, levodopa. Is that going to just make me horribly dizzy so that I won't be able to function?
So are you on carbidopa, levodopa currently?
Nothing yet, because it's only been 2 weeks.
Got it.
And the doctor is still trying to determine whether it's multi-symptom atrophy or supranuclear palsy or traditional Parkinson's.
Got it. Yes, it's potentially it can get worse. And one thing to do is to investigate further. So usually what I ask my patients to do is to measure blood pressure at home, sitting down and then standing up, do that for about a week. And if I have a convincing data, then I'll probably treat the lightheadedness first before I try carbidopa, levodopa in that situation.
Yeah, and then I tried fludrocortisone, that just made me wacky. I mean, I couldn't even function on that medication, and I was only
Got
taking
it.
half of the lowest dose.
Oh no.
Yeah,
So another medication, there are other medications as I listed out. You can use midodrine, you can use droxidopa, or also called Northera, which tends to be more expensive, but that is also available. There's atomoxetine that's also available. So those are the medications you can definitely try. So you're not out of options here.
Okay. And can you explain the difference between off time and on time?
Yeah, so off time is basically when the medication is off. The carbidopa, levodopa is off. On time is carbidopa, levodopa is on, like a switch. So on time is the time when you can move better, your speed is going up, you're less stiff, you're less tremor, and off time is more stiff, more slow, more tremor, and you're almost frozen.
Okay.
So the other question is for folks with young onset. Is there more of a chance for dyskinesias?
Yes. It only makes sense if you think about the math. Longer you have Parkinson, the more likely that you're going to have that receptor changes in the brain. Therefore, you're going to have dyskinesia. So let's say if I'm diagnosed with Parkinson at age of 70, and I had it for 20 years, I'm now 90. Am I going to have dyskinesia? Sure. If you're diagnosed with Parkinson at age of 40, 20 years later, you're going to have dyskinesia. Sure, you can have dyskinesia, but at that point, you're going to be only 60, as opposed to for the 70-year-old who got diagnosed later in 90 having dyskinesia is a little bit different. So it's more of like a math type of thing, if you will. Yes, you're going to probably have a dyskinesia sooner, more longer time. So if you have dyskinesia, so you have onset of Parkinson at 40, and you have dyskinesia at 60, it's going to progress more over that 78, 90 once you get to that level. As opposed to other patient who has it later and they have dyskinesia at, I don't know, 80 or 90, they're going to pass away at 100 or 110, I don't know.
Yeah.
So
no, it's nearly normal lifespan. So yeah. Yeah. All right, other questions? Dr. Kim's got to go see a patient really soon. So any other burning questions before we let him go back to clinic?
Let me just make sure that I have patient arrive.
Okay.
Until then, I have time, I think. I think one thing that I didn't focus too much today is the exercise, because I know you have a talk coming on.
Mhm.
Out of all things that I mentioned today, the levodopa, dopamine agonist, or Pinerol, Rytary, DVS, or all of these are to improve the symptoms. We don't have a medication that slow down. We don't have a medication that slows down the disease, but exercise can. So
Do you
again,
mean aerobic exercise or like yoga or Tai Chi? What kind of exercise?
great question. You should just come next week.
Yeah,
Yes,
no,
Nate.
I will.
Nate will talk about that. Yeah, he'll talk about sort of the prescription. And I would say, and we'll see if Dr. Kim agrees with what I would say, is find something that you love and that you will be consistent with. And as Michael J. Fox once said on an interview, do something that makes you pant every day.
I like that.
So, get your heart rate up a little bit, but there's certainly things that you focus on with exercise, but find something that you love that you'll stick to.
That's the most important one I want to say. Yeah, I agree with that. Yeah, just the 2 cents. I agree also get you to pant and get your heart rate up, more of an aerobic type of exercise. You want to get that idea, I think, is, we don't fully understand, but you get that circulation going and you get rid of that bad proteins better. And that probably is what's helping the most.
And you'll learn a lot more about it next week.
Exactly. All right. So my patient's here. I'm gonna go. It was great meeting everyone.
Thank you, Dr. Kim. Will you email me your presentation so I can share it?
Oh, yes, definitely.
Thank you.
All right. I'll do
Thank
it
you
tonight.
so much. Okay.
Goodbye.
Bye-bye.